Yeah, good morning. Thank you, Dr. D'Souza, for inviting me here to talk on this topic. So today I'm going to talk about immunotherapy and the role in extensive stage small cell lung cancer. So it comprises around 15% of all kind of lung cancer, but it's still a deadly disease. It's mostly in the older age. The median age is 70, and almost half the patients have brain mets or develop brain mets eventually. And it's a disease almost exclusively for what happens in a smoker patient. And most of the patient, around two-thirds of the patient, presents in advanced stage. And even with chemotherapy and all the treatments, still they have a very dismal outcome of it. At 5 years, hardly anybody survives. So advancement basic, which we are using as a standard backbone, was developed almost 40 years back, a topocyte platinum combination. And then various innovation came, particularly in the field of early, small cell lung cancer with thoracic RT. Then topotecan or irinotecan was used in a second line treatment. Then came immunotherapy eventually, and now we have immunotherapy combination first line to treat small cell lung cancer. So as we know, the standard is to give a platinum doublet. 4 to 6 cycles is given. Then we give either PCI, which is most of the times used, or it depends on the what our physician is treating. And a patient who progresses more than 6 months later, we can again re-challenge. And within less 6 months, we have multiple options, but still their outcome is very dismal. But now with this immuno-oncology, now we have 2 drugs which are approved in first line along with chemotherapy, durvalumab and atezolizumab, which have slightly improved the outcome of these patients. Even if we use immunotherapy, most of the patients will respond to chemotherapy. Almost 75% patient response, but they eventually relapse. Most of them patient will relapse within 6 months, and ultimately leading. This is the reason, because we don't have a sustained response of these drugs, that these patients have a dismal outcome. And again, as the patient is not eligible also for subsequent lines of treatment, hardly any patients receive a third line therapy. I'll say less than 20% of patients even receive a second line therapy in small cell lung cancer. Even with the use of this now immunotherapy, again, not all the patients respond. Again, the response rates around 60 to 70%, and a typical PFS is still same, but we have a slightly long-term benefit is seen with the adding of immunotherapy. Same thing is repeated. So basically, this is a Caspian study in which they have combined immunotherapy, either cisplatin or carboplatin, with a topocyte with durvalumab versus just chemotherapy arm. The primary endpoint of this study was overall survival. And Caspian study, it was slightly different from the IMpower 133, which is the atezolizumab study, is that in this, both the cisplatin and carboplatin was allowed to be used. And in the just chemotherapy arm, up to 6 cycles was allowed, which is most of us use 6 cycles in this setting, although there is not that much difference between 4 to 6 cycles. And patients who had received prior treatment for brain mets were only allowed in the IMpower study, but in this Caspian study, asymptomatic untreated brain mets were also eligible. And as we can see, this is a long-term outcome. At 3 years, 17.6% patients were alive compared to 5%. And there's a sustained benefit beyond that also. The median OS was slightly better, but it was a significant 2.5-month difference was there by adding immunotherapy. And those around 17% patients have a very good long-term outcome as well. If we compare to IMpower, in which atezolizumab study, which we have only 2-year data, and we compare both, around 22% patients are alive at 2 years. We don't have the long-term data for IMpower, but Caspian 3-year data, as I told you already. And if you look at the subgroup analysis, almost all the subgroup of patients, irrespective of brain mets or smoker status, almost all the patient subgroup benefited the immunotherapy combination. Even the response rates were higher in the immunotherapy combination, around 67 versus 58%. And depth of response, patient who responded, they continue to respond for a long term. And PFS was, though not different, median PFS was similar, but the patient who responded continued to respond for a long time. Almost 10% of patients were on durvalumab at 3-year cutoff. And the patient who had brain mets or didn't have brain mets didn't make much of a difference. Even patient with the baseline brain metastasis, median OS was significantly improved, 12 versus 8 months. And similar was the case in patient without brain metastasis. And if we look at the 24 months safety profile, there is not that much numerically difference in the adverse events. Grade 3, 4 adverse events were similar in both the arms. obviously immune adverse events will be higher in the durvalumab arm, but it didn't make much of a difference. So there was slightly higher treatment-related adverse leading to death in the immunotherapy combination. Similar thing was seen at the 3-year cutoff, that there was not that much difference and there was no new any safety signal was seen at a 3-year cutoff. It's similar amount of adverse events in both the arms. And looking at the quality of life and the deterioration in function in all the major scales, it showed that giving immunotherapy led to a better quality and delay in the deterioration of any quality of life, as well as in any symptoms like dyspnea or any cough, which were slightly better in the immunotherapy arm. So durvalumab is usually given as a fixed dose of 1500 milligram. It's given along with platinum therapy. Then it's given as a 4-weekly dose as a maintenance therapy after 4 cycles of chemotherapy. So this is the study difference between the Caspian study and the IMpower 133. Patients, first thing was that cisplatin and carboplatin both were allowed in Caspian, whereas cisplatin was not allowed in IMpower. And up to 6 cycles of chemotherapy were allowed in the control arm in the Caspian, whereas in the IMpower only 4 cycles were given in the standard arm. And PCI was allowed in the IMpower 3. Those patients were usually excluded in the Caspian study. So Caspian more or less, is reflective of the real world clinical practice, which is commonly been done for most of our patients. So based on both these trials, now both the immunotherapy combination with chemotherapy as per NCC and also the category 1 recommendation and the preferred regimen. So to conclude, immunotherapy combination durvalumab plus chemotherapy has shown a sustained improved in OS even at 3 years. And it is the only IO which has been used along with cisplatin or carboplatin. And benefit was seen even in patients with brain metastasis. Around 17% of patients are alive at 3 years. And it showed a higher response rate, and that almost 10% of patients are still on immunotherapy at 3 years. Thank you.
Thank you, Ankur. Any questions? Thank you.